Okay, well, this is the case that we left off with last time, which is a little older baseball player, and we're just seeing these chronic repetitive impaction injuries in the glenoid, typically the superior part of the glenoid, anterior superior glenoid here is a baseball injury, repetitive glenoid impaction. So, see, Jennifer, what do you take? Why don't you take this one?
So she has sharp pain on throwing, rule out labral tear. I don't see anything here along that superior labrum. I don't see any abnormal contrast signal intensity along the superior labrum. Yeah. There. I guess those maybe some subcortical cystic changes. So it could be due to repetitive injury without detached labral tear. Yeah.
This is also due to repetitive trauma from throwing, but this is in a younger kid where you typically are looking more for growth plate disease, but this is really due to repetitive impaction.
All right, so 12-year-old motocross accident. Looks like there's a fracture there. Where is it?
Hi, John.
Hi, John. Sorry, for some reason I didn't get the.
Did you finally get it? The link? Oh, well. Thank you for joining us. So, yeah. Well, this is probably the growth plate.
Growth plate, yeah. No, I'm talking about the glenoid looks a little irregular there. Yeah, yeah. I thought that was a fracture.
But that's, you can also have a growth plate in through there.
Mm-hmm.
What do you think it is?
I'm just looking at the humerus there. It looks kind of irregular along that lateral margin.
The glenoid. What do you think?
Glenoid there doesn't look too bad.
What do you mean too bad? 12 is a 12-year-old.
Yeah, I guess that's true. It is irregular for a 12-year-old. And there's some remodeling there of that inferior glenoid as well. And then obviously some marrow edema at the physeal plate, but that could be normal in this age group. But the glenoid looks markedly remodeled and abnormal there. Especially it only occurred 1 month later. I don't know if there's an inferior labral tear as well. It looks like there might be some.
And the physis?
Yeah, the physis has some increased signal and some widening, I thought.
So the x-rays here, I wouldn't say.
I think on the x-ray, John, what do you think that is?
What are you referring to, John?
Glenoid, the lateral aspect. Or posterior aspect of the glenoid.
Are you talking about back here?
Yeah, is that a growth? Something?
I don't think so. But I would be a little concerned on the plain films. But when we go to the MR scan, the main thing I see here is a lot of edema around the growth plate of the humerus.
Yeah, the physis.
Yeah, the physis. And here we can see this is abnormal thickening here and a lot of irregularity. The physis should be nice and smooth all the way through here, and a little irregularity there. And this was a Salter-Harris 2, where a little fracture through here.
How about the periosteum there too? Is that
Yeah, there's periosteal thickening here.
Yeah.
Go back here. There's periosteal thickening here as well. And there's
Right. So it's a healing process.
yeah. So this was a Salter 2 coming up over through here. Okay. Michael, what do you think of this case?
Okay. So there's low. I assume this is a T1 coronal. There's low signal intensity in the lateral humeral head. It looks like there's either subchondral cyst or kind of erosive type change in the glenoid as well, and maybe that's either a little bony fragment or marginal osteophyte projecting off the inferior humeral head.
This was a bone island here.
Okay, so it's just a little sclerotic bone island.
So this is and these can either be due to direct impaction injury, or you can have a traction injury of the two. Typically, with the direct impaction injury, you get more amorphous edema, which we now see best on the PD FATSAT images. With traction injuries, you can get edema, or you can just get a thin line here. With traction injuries, you can actually have not very much edema, even in the acute setting.
Is that a loose body down there in the joint inferiorly?
Right here, you mean?
Yeah.
I don't remember, John. I'd have to look at all the other images.
And the dark structure that you're looking at, is that a surgical?
This is a bone island.
Bone island?
Yeah. But we'd need the other images to confirm that.
Well, okay. I'm sorry.
That's fine.
I'm jumping the gun.
Well, that's okay. Forget it. Just okay. Jennifer.
All right, so fall off a ladder in October 2019. It looks like there's diffuse edema within the greater tuberosity. I'd be concerned about a fracture of the greater tuberosity, although I can't see a fracture plane here. And here again we see diffuse edema in the greater tuberosity and some supraspinatus tendinosis, and there is some linear fluid signal intensity kind of longitudinally. So I think this may be a non-displaced fracture.
Extensive trabecular injury, a lot of either tendinosis or strain of the rotator cuff tendons. So that was on 10/23/19.
I cannot hear you, John.
Then there was acute injury, and here the patient came back a little bit later, 3 months later.
Okay. So now we have a large osseous defect in the region of the expected greater tuberosity and full thickness, full width tear of the supraspinatus, and also at least partial thickness, full thickness, partial width tear of the infraspinatus. There's tendon retraction, and I don't see an osseous fragment in the joint space, so I wonder, oh, there it is. Okay, so that pulled that osseous fragment off.
So this started out as an extensive trabecular bone injury, but anatomically it was intact. But as you said, there's a lot of trabecular injury here, and you'd worry about the stability of this. And then following up 3 months later, we can see that the traction from the rotator cuff pulled off the bone, displaced it immediately, and now you have a big osseous defect there.
This was a surgical case from the get-go.
Yeah. So
this is not a young patient, is it?
It's a little more difficult at this point in time.
Yeah. I don't know the.
Well, when I say little, I'm being facetious.
Yeah, right. Really.
Okay, here we can see that there's some posterior subluxation of the humeral head and impaction injury there. Displacement fracture in the posterior glenoid.
As well as reverse Hill-Sachs infection.
see extensive edema, maybe a kind of minimally displaced fracture involving the greater tuberosity, and it also extends intra-articularly. And
Did you say the greater over here?
so there's like one that's kind of going, perpendicular AP direction in the greater, and then there's another component of the fracture line which extends right there, kind of intra-articularly to the lesser, yeah. Mm-hmm.
Which is involving the articulating surface.
Mm-hmm. So it's like a comminuted fracture of both.
So this is probably a four-part, which comes from near, where you talk about the near classification, where you basically on plain films is what this is really developed, is you look for the number of different bones here. So these are non-displaced, so that would just be one part. Here you have one piece of bone displaced, that's two. Here would be a three-part fracture, a four-part fracture, and then you get more complex areas as well. So again, it's just, I think it's important to describe, obviously if there's any displacement, but describe the fragments and where they're located. So what do you think of this one?
All right. So this is a comminuted fracture of the humeral head with both transverse components through the surgical neck of the humerus and longitudinal fracture plane undermining the greater tuberosity and exiting the superior humeral head. This is probably at least a three-part fracture from what I can see, and it would be unstable. It looks like the supraspinatus insertion attaches to that dominant greater tuberosity fracture fragment.
I'd say it's a four-part.
Yeah, we'd need to see all the other images. It may well be, John. This
Yeah, it's
see the three, but it may well be a four-part. Yeah, good, John.
but anyway, what would you do with it?
John, let me ask you a question first. What else would you like to see in the radiology report?
Mainly the displacement and the number of fragments. I don't go by the near classification.
Okay.
I went to school before near, and I got to know him a little bit in the literature later, but anyway, the classification other than after three, it's the displacement and the age of the patient that you want to know.
And I would say here too that
how many fractures, I mean how many fragments.
so here we can see the articular surface of the humeral head, or the dominant medial fragment, is displaced inferiorly in relation to the glenoid. We would measure that.
We don't know how much of that head is there because we only have two views.
Yes, that's very true. And there's also some mild impaction. We can see some superior displacement of the dominant distal fracture fragment. And there's some fracture overriding as well of that greater tuberosity fragment.
I have a feeling, if I was to guess, that this is a patient in the late 60s or 70s, and this patient would get a shoulder prosthesis.
I don't remember what happened here, but yeah.
But you wouldn't try to fix this. That it wouldn't work out.
86-year-old male status post fall with fracture dislocation, evaluate status of tendons. Well, you see a pretty extensive fracture of the humeral head. I don't really see, I saw one bone fragment superiorly there, but
where is the humeral head?
Yeah, I think it's pretty chronic there. I think it's inferiorly displaced under the glenoid, and that's and medially displaced. And then there's another fragment you see within the joint space, and the tendons are quite tendinotic. It looks like there's some intact though. I don't see fluid, but they're
the different tendons were intact to the bones, the bony fragments that were displaced, and John, why are they mostly interested in the tendons, how the tendons are, and the deltoid is also?
The tendons, in terms of whether you do a reverse type total replacement and or a prosthesis, single prosthesis and cement. When you get to 86, you get a single prosthesis with cement in a shaft, and they work out fairly well. Obviously, it's not a new shoulder, but it works okay. And the main thing is the pain. Shoulders are notorious for pain because of absence of tendons.
Yeah.
But in this case, you can always reattach the tendons. At least it looks like you can, but you need more more views, I think.
Yeah, and we'll talk about what you look for depending upon whether you want an anatomic prosthesis or a reverse prosthesis later in these.
Okay.
Yep. Good.
I just mentioned it, judges.
Good. Thanks, John.
Okay, so this is a, looks like this is going to be a young kid because we see the growth plates of the superior glenoid. We also see growth. Is not 20-year-old? Well, they still have, it still takes a while for all those to fuse. But like we see a defect there at the base of the coracoid and the superior glenoid. So I guess if they're not that young, then that could be an injury, like a coracoid fracture.
This was a fracture.
Okay.
Okay, so here we have a dominant transverse fracture plane through the surgical neck of the humerus, and there's some distraction of that inferior humerus with respect to the humeral head fragment. So I'd measure that intra-articular gap. Gosh, I can't tell if that's an additional fracture or if this is hemorrhage and granulation tissue. I wonder what the age is of this.
Yeah, this is pretty old, I would think, don't you, John?
So that's probably, yeah, there is some corticated margins here and hyperostosis. This is chronic non-union.
I think the problem with this patient, it was probably treated with a hanging cast or some weight on the shoulder, which is something you should never do. Sling, and that's it.
Okay.
Is the treatment of choice. You start adding weight, that's what you get right here every time.
This is hypertrophic bone, showing the chronicity of the disease.
What happens with patients when they have this injury, they try to test it to see if it's healing or not. And by testing it, they keep moving the shoulder. And I had a patient that had a non-union because of that. I did a pretty decent operation on the patient. She happened to be a secretary for the LA County Medical Society. That was kind of a, I don't think she told anybody because I reoperated on her. I noticed what the problem was, but she kept shrugging her shoulder, and I made sure she had an abduction splint the second time around, and I redid it and grafted it, and it healed, and she was very happy. So that's one problem with this fracture.
Thanks, John.
It's that the patients keep trying to test the success of it.
All right, so we have an 80-year-old female with shoulder pain and loss of range of motion for 1 month, 2 coronal images here. And just looking at that greater tuberosity, it looks like there's kind of traction injury there, maybe some partial interstitial tearing there. Are we looking more medially, or is that just artifact? Okay. It looks like, is that tendon? No. Oh, okay. Almost looks like separated tendon fibers, but it's not. It's bone. Okay, so this is a clavicle.
So this is a non-union scapula fracture.
Okay.
Not common, John, but it does occur, doesn't it?
It does occur. It's not very common, but you can, if there are big things that you're not used to looking for, it's easy to overlook them. But it's obvious.
That means the examination wasn't too good.
I don't know. Yeah. Okay, Michael.
Okay. So what I think I'm looking at there's some irregularity along that glenoid, the inferior aspect of the glenoid. I'm not sure what that dark signal I'm seeing coming in is.
This thing?
Yeah. Is that just part of the?
What's that? What's this?
Exactly. I can't tell if that's cortex of something. Scapula, yeah.
So remember, it's a thin sheet, basically, and that's what it looks like when it fractures.
All right, so here we can see a comminuted fracture of what we can see of the distal scapula, and I don't see any discrete extension through the glenoid, although posteriorly there may be some intra-articular extension.
Do you think it's comminuted?
Yes, I do. I see multiple regions of linear fluid signal intensity compatible with multiple fractures.
I agree with you, and it's very important to, when you start thinking surgically. Now here, I don't know what the age of the patient is, but that's important. And then this is a tough one to play with surgically. I'm being a little debonair here. This is a sling and swath type of a project. If the patient is in the 70s or whatever. A younger patient, it would be an interesting operation. Probably you would need the external fixator.
Mm-hmm. I just want to point out how easy it is to actually miss these because we're not used to looking at the scapula.
Well, the X-ray would show it, John.
Okay, this is a 74-year-old male with pain after trauma with 3 coronal views. Looks like there's a, I think this is a at least you see one part fracture extending through the greater tuberosity, and also interarticularly, there's also, I think, a fracture of the glenoid inferiorly. See a lot of marrow edema there and some decreased T1 signal there, the inferior glenoid. So. And you can see the fracture here in the axial plane. There's some mild displacement.
So it's on 10/5/2010.
Well, there's also angulation, I think.
Yeah, some minimal angulation.
So a few months later, this is.
Oh, okay. So you've got some partial osseous healing of the previous plane of fracture, and you've got a big endesophyte coming off of that greater tuberosity, and then you have another part. Oh, it was there. Okay. And then you have you have another fracture actually on the superior humeral head almost like a V-shape fracture extending there.
And this is a 4+, I think, and with considerable displacement of the greater tuberosity. What would I do? We'll talk about this later, I guess, but a sling and swath.
Let's continue with the differential diagnosis here first.
Yeah, let's do that.
So I guess the question is, what do you think this area up here is? And then here are just some other images going up higher. And notice that superior area was not abnormal at the time of right after the fracture. So what else could it be besides the fracture up there?
Besides a fracture, I guess it could be a displaced fragment.
I don't think that's what John's looking for.
Okay.
I think this is that's what you can get after fractures, depending on where they are. They're probably not as common as we once thought they were, but this is post-traumatic AVN, and you can see the double line sign here.
Just like a hip.
Yeah, just like you can get in a hip, right? So, and then, okay, Michael.
History treatment for breast cancer fracture 1 year ago, 3 months increasing pain. So we see that, linear high signal of the superior humeral head, kind of similar to the one we just saw. I don't know if this could be another thing of AVN.
All right. So here we can see diffuse decreased T1 signal along the medial aspect of the humeral head with a double line sign adjacent to that, the serpentine increased and decreased signal intensity, and there is some depression of the subchondral bone plate. So this is compatible with AVN and subchondral collapse.
Okay, this patient's a professional diver. On the T1 and T2, we kind of see a serpiginous low T1, high T2 signal. So at the superior medial humeral head, and there's also something more inferiorly within the humeral neck that's concerning for AVN, avascular necrosis.
Caisson's disease.
John, are you getting cases nowadays of Caisson's?
Not very often, no.
I wouldn't think so. I think that Southern California has oxygen.
Yeah, there are decompression chambers, right?
Decompression chambers. I think 3 of them.
Yeah.
I'm sure they have one in San Diego.
Yeah. So I think everybody knows what Caisson's disease.
And I think Long Beach has one.
I think you're right. Michael?
Okay, so 35-year-old male with ulcerative colitis and shoulder pain. So we can just see there's kind of extensive avascular necrosis throughout the entirety of the proximal humerus. Yeah. Steroids.
All right, so shoulder pain, rule out mass. I don't see any discrete lucent lesion, although there's some faint linear signal intensity kind of along the inferior aspect of the greater tuberosity. And then 11/2/2005. Yeah, I guess there's that lytic lesion in the anterior superior or superior lateral aspect of the humeral head.
So do you want to see an MR scan?
Yes, please. Okay. So this must be a chronic greater tuberosity avulsion from an untreated fracture there undermining the greater tuberosity.
Yeah. On the X-ray, don't you think there's a soft tissue bump there over the greater tuberosity, the deltoid?
I'm not sure, John. There may be.
The deltoid is kind of prominent above it. Yeah, right there.
Yeah, that's the subcutaneous tissues. But this patient probably had a little traction trabecular bone injury at this time, which we can't see on the CT.
Well, they're probably swelling and bleeding.
Yeah, and then here we can see it's probably started to displace at this time, and then here we can see the injury. Okay, another patient.
Here you can see that the greater tuberosity is absent and looks like a lot of high signal there, probably a prior avulsion. There's also increased signal within the humeral neck and some bone marrow edema there. Looks like, is that the part of that subchondral plate? Mm-hmm.
We haven't talked about acromioclavicular joint, Joe. I guess we haven't talked about that yet. Okay, yeah, let's talk about acute injuries to the acromioclavicular joint. One of the few classification systems which really seems to be universally used is the Rockwood classification system for AC joint injuries. You all have heard about it. So normally you have the acromioclavicular and the corococlavicular ligaments intact. A type 1 injury, you have a sprain of the AC joint capsule, but the CC is intact. Type 2, you have a rupture of the AC capsule and the CC ligaments are sprained or partially torn. Type 3, both of these are ruptured, but you don't have significant displacements of the bone. And then a type 4, and these were described in the order that he basically saw them. Unfortunately, it's not the order that you would put it in from a pathophysiology standpoint. A type 4 is a type 3, but you have a posterior displacement of the clavicle. A type 5 is basically a type 3, but you have increased separation of the AC joint and generally injury to the retinaculum superior to the joint. And then type 6 is an inferior clavicular dislocation. So as you know, here would be the AC joint, and then we have the CC ligaments here and here. So let's see what it looks like on MR. So on MR, whenever you see or are concerned about an AC joint acute injury, you have to look carefully at the sagittal images looking at the corococlavicular ligaments here. There are two, but they blend into each other on MR scan. And this is intact CC ligament, which we see here. So in a type 1 injury, what you see is kind of indistinctness of the AC joint space. We're not quite in it here. You see a lot of capsular edema surrounding it, which is a capsular injury. But then the CC ligament should be intact, looking at the sagittal images. So here's another example. We basically have a capsular injury with a little bit of fluid adjacent to the capsule. In this particular case, we actually see a little erosion here. This patient probably, like most of them, have acute on top of chronic disease. And then we need to go to the CC ligaments. Now, one thing, especially in older females, the CC ligaments may be kind of small. So sometimes they're obliquely oriented with respect to the sagittal plane, and you have to follow them. But here the CC ligament is intact if we follow it on the two sequences. So this would be another type 1 injury. The coronal images can also be very helpful, where we can see the CC ligaments here. Oh, this was a football player. Okay, that was another type 1. Now we did a study a number of years ago in Ironman athletes during a big Ironman competition in Hawaii, where we looked at the AC joints. And this is one Ironman who had a lot of pain. We can see there's a lot of edema on either side of the AC joint, a lot of irregularity of the articulation here. And here we can see a little bit of osteolysis of the at the AC joint in this particular patient with very indistinct distal margin. So this is very common in repetitive injuries. And as you know, on plain films, if you have multiple repetitive injuries, you can actually erode the distal end of the clavicle, and you can get indistinctness of the distal end of the clavicle on plain films. Plain film findings are very late. We can see that much earlier on MR examination. And here again, we can see the marked irregularity of the articulating surfaces of both the distal clavicle and acromion. And this is very typical of repetitive trauma to the AC joint. So this is what AC osteolysis looks like. And we can see this far earlier on an MR scan than you can on a plain radiograph. If you look at this, if you look at the amount of forces going through the AC joint, it can be really large, greater than 1.5 times body weight. So that can lead to significant injuries. And as you all know, almost every adult, especially when they get older, have degenerative changes of the AC joint. It's rare for us to see a normal AC joint in someone over the age of 20.
The acromion is tugging on that clavicle all the time.
Yeah.
It's we think the clavicle is superiorly displaced, but actually it's the acromion that's inferiorly displaced.
Yeah. So then the type 2 lesions, we have a rupture of the AC capsule and the CC sprain. You can see here. So here in this case, we can see abnormal fluid tracking along an injury to the capsule. And then if you go to the sagittal images, this is from an article from 2003, so it's a little bit old. We can see a lot of edema in the CC ligaments. So this would be a sprain of the CC ligaments and a capsular injury. So this is a classic type 2. Here's another one where we can see an injury to the superior capsule there. And then if we go to the CC ligaments, we can see a lot of increased signal intensity. If we get the rotator cuff tear, here we can see an injury to the AC joint with some separation. And then if we go over on the coronal images, we can see a disruption of the CC ligaments here in the coronal plane. And then here we another example where we can see a edema going all the way around the distal end of the clavicle due to injury to this AC joint and some separation. And there we can see the fluid coming out through the capsular tear. And this was also a Rockwood 2. Now 3, we get ruptures of both. So the key point with the 3 is you have CC ligament tears. Now in the past, the big division was between type 2 and 3, where types 1 and 2 were treated conservatively and most types 3 were operated on. Now most types 3s are also not operated on, but some of them are. So now the differentiation is primarily between 3 and 4, 5, and 6. So what does 3 looks like? Here you have a tear going all the way through all 3 components. Here we can see a big separation and AC joint space. Here we see, and as John was saying, there's a little bit of a decrease in of the acromion process here, which inferiorly displaced. And here we can see a nice discrete tear through the CC ligaments on the coronal images. So that would be an acute type 3. And on the sagittal images, we can also see the tear in the CC ligaments. So that would be a type 3. Most of these are treated conservatively, but if they have persistent pain or other complications, some of these will still go to surgery.
It's either you have a scar or you have a big bump. And I've had patients force me to operate on some of these because they didn't want that bump.
Okay.
I don't like to do cosmetic surgery, but sometimes you just have to. Like when you suture patients, I never left suture scars. I use those subcuticular stitches and steri strips. They're using them now, but and surgeons like staples, and I hate staples.
Okay.
I had them when I was 12 years old and had a hernia repair, and I had staples, and they have been within 10 years or so, the staples were thrown out and reappeared about 10 years ago.
Okay. Okay, who's next?
Injury during the Stanley Cup Playoffs. It looks like there's scapular injury at the acromioclavicular joint, a lot of fluid extending there. Want to look at the AC joint. Looks like there's a tear of that corococlavicular ligament right there. I think it goes all the way through. Yep, it goes all the way through. So looks like a type 3.
That was kind of the end of the season, so yeah, he was actually treated conservatively and did well. Michael?
John hasn't mentioned X-rays and weights on either hand, 5 pounds no more, and AP shots to see if there's displacement, and it was thought that with weights on and displacement that would mean that the CC ligaments were torn, and sometimes they would be partially torn, and it's still done, and it hasn't been discarded, that procedure. But most times, of course, it's MRI nowadays. But some orthopods still use it.
Thanks, John.
So in this case, we see first image, we see capsular injury of the AC joint, mild separation, and capsular disruption. On the second image, it looks like we see a fracture through the coracoid, as well as marked signal and irregularity at where the CC ligament should be. So it's completely disrupted, it looks like. Yeah, it might actually just be the growth plate.
Alright, so this is an 18-year-old male with shoulder pain after trauma, and there is soft tissue edema and fluid signal intensity surrounding the, looks like, distal clavicle. I don't see the acromion on this image. Okay. Here we can see separation or disruption of the coracoclavicular ligaments, and there's also a displaced ossific fragment. Oh, this is an avulsion.
That's actually a avulsion rather than just a tear through the ligament. You can see the bone avulsion coming off there. So that's what?
I cannot hear you, John.
Oh, so the question is whether this is operative or not.
It's really, it's up to the patient. I think it's one that either you may want to do or you may not. Depends on the patient, like most operations. But I would suggest that this probably should be done surgically.
Yeah,
it's not that difficult to do.
I don't know what they actually did with this patient. This is from Dr. Taylor.
He's 18 and wants to look nice on the beach, I suppose.
And then there's type 4, which is a posterior displacement, which we can see here. So normally the clavicle would come up here and articulate anteriorly with the acromion, and here the clavicle has been posteriorly displaced with tears of the AC capsule as well as the CC ligaments. And this is a surgical case.
All right, so 28-year-old male with shoulder pain 2 weeks after a motor vehicle accident. We can see quite a bit of fluid and disruption of the AC joint. I don't really see the distal clavicle here.
So here's the distal clavicle.
Okay.
Here's the acromion articulation.
Okay, so it's definitely well, there's quite a bit of separation there. It's probably posterior to the clavicle because we're pretty far anterior.
So here we're posterior.
Yeah.
Because the articulation of the acromion is very
Anterior, right.
And we see the distal
Clavicle
posterior
to yeah.
And anteriorly where the acromion articulation is, that we don't see the distal clavicle. So this is a posterior dislocation. This is a type 4. Here's the axial images. And if we go up one cut up, so here, so there's the axial images through the head, and then here's one cut up where we see the distal clavicle.
Right. And here you can easily see that the distal clavicle is posteriorly displaced. And is there some osseous fragments on that other image? No, okay. And the corococlavicular ligaments are, of course, disrupted here.
So that's a Rockwood type 4. They're pretty uncommon. Okay, here's a snowboard injury, Michael.
The reason that these are not that common is that a lot of these patients don't make it to the ER. These are high velocity injuries.
Okay, so on the first go, we can see the distal end of the clavicle, and we don't see the acromion. So it looks somewhat superiorly displaced, and it also looks superior and posterior displaced. So it's kind of like almost like, let's say like a type 4 or even type 5.
Well, it's actually the acromion anteriorly displaced, but these are real severe injuries. And not just to the shoulder, but the whole body.
So you see the distal clavicle, it's kind of up and it's kind of protruding into the overlying trapezius muscle. So it's kind of like dislocated into the muscle.
Yes, it is. You cannot reduce these.
Yeah, like stuck within the muscle.
Yeah, if you try to reduce them, all you do is just make the muscle tighten around it. And you wouldn't really want to try because it's main thing is you do the blood work and then go to surgery.
Now we can go to type 5. Type 5 is really a separated type 3 where we have all three torn and typically prominent inferior displacement of the scapula. And here we can see now there's a little bit of a disagreement as to what criteria you use to make this diagnosis on MR. But typically, if the superior cortex of the acromion is below the inferior cortex of the distal clavicle, and you've got greater than a centimeter of separation, then it's most likely going to be a type 5. You also look to see if you have an injury to the muscle and the retinaculum superiorly here, and sometimes you can actually see a disruption of the muscle and the fibers there. And then here we can see the CC ligaments are torn.
I thought that 5 is the acromion is above the clavicle.
No. I don't think so, John.
Okay, I've been wrong before, John.
Yeah, that's a type 6. So, and
we went to only 5, and I guess they added a new one.
Okay, yeah, and then here we can see that there's significant separation. This is the injured side. This is the normal side over here, and that would be another type 5. And then here, the MR scan, we can see the displacement and all the edema between the two. And here we can start seeing some injury to the superior soft tissues here from the injury and the ligament tear. That's another Rockwood type 5. And a fascial tear above it we can see. And here's another type 5, tear the CC ligaments, and again the inferior displacement.
And these are not easy to do.
Yeah. And then this is just a diagram of the different types. And we haven't gotten to it yet. The type 6 is what John was just referring to, where the clavicle is inferiorly displaced, inferior to the coracoid process here. And right. So I don't have any examples of a type 6 because I've not seen it on an MR examination.
Didn't survive, John.
Yeah, that's probably true. So let's see, who's next? So this patient had surgery.
It looks like they had repair of the coracoclavicular ligaments. A lot of times they do a tightrope fixation. They connect the coracoid to the distal clavicle.
Yeah, there are a number of fixations here. This we can see that there's a metal artifact going all the way through here. And this is one technique that I haven't seen very often, which is basically
That's a Bosworth screw. My favorite screw for doing a Bristol procedure for dislocated shoulders. I don't like to use this Bosworth screw in this condition. I like to use sutures. And you don't have to take sutures out. This you have to remove in 6 weeks. And putting that screw into this area is quite dangerous, and you have to drill a hole through the clavicle. You have to drill a hole through the coracoid, and then you have to put the screw in there and get it, make sure that it enters the right spot. And do you have a minute, John, that I can tell a little story?
Sure.
I got a call from Curlin and Job's location. My mentor, Dr. Blazina, was working in there at that time. He called me in my office. He said, "John, what the hell do you use to fix AC joints nowadays?" And so I told him about my suture technique, and he said, "Thanks a lot." And away he went, I guess. He didn't tell me what kind of result he had.
Okay, nice.
But there are so many different operations to do that I'm not sure I want to take up the time, John, for you. You got a lot of traveling to do here.
Okay, good. Michael, what do you think?
Okay. So, 49-year-old male with recurrent pain after CC repair, rular root tear. So we see on the first image kind of low signal, linear signal going into, the region of like a repaired CC ligament. But it looks somewhat separated to me. Yeah, like it looks like a pretty big distance. So I'm wondering if it is retorn.
This was a suture.
The fact that you see it separated, that's why we have so many different operations. Because there's not a single operation that works 100% of the time. Yeah. So you choose one that works the most, the best for you, and that's the one you use.
Yeah, and here we can see the hole there, and then.
The problem is that a lot of these holes are missed when the screw goes in, and then it goes into soft tissue. The patient wakes up, and dislocation is there again after the anesthetic wears off.
Wow. Right.
Bad news. That's why I don't like that screw.
Yeah.
And that's why it was made by Bosworth for this condition.
So
I like the screw, but for another condition.
it's important to look in multiple planes here because we can see the sagittal plane that it is intact. Okay, what do you think about this one, Jennifer?
Well, on the plain film, there's some irregularity of the AC joint and some widening of the corococlavicular distance. So I'd be,
What is that?
yeah, I can't see it looks like,
Oh, sure you can.
it looks like there's, the coracoid is actually, it's more spirally located than I would expect.
What is they're ligaments and they ossify. They calcify from all the blood and then they ossify, and there you have it. And it's probably a type 2.
See, both of these ligaments ossified in that particular patient.
I had one ossify on me after surgery.
Yeah. The other thing that you can see sometime is kind of partial ossification, and then what you can have is actually an articulation here instead of having the ligaments, and you can get a lot of variation in the normal anatomy here. This patient was painful in this area, and if we got an MR scan, we can see why. That basically the patient has a pseudo articulation there in that particular area, and this has a lot of degenerative disease and was causing a lot of pain. So that's a pseudo articulation of the CC ligament.
I guess I would probably excise that articulation and so that the bones don't rub.
Exactly right.
In some article I read, they called those conoid processes.
The conoid processes.
They call them conoid, like I think I guess the conoid.
Well, the conoid is, the two ligaments. One of them is the conoid.
Yeah.
So that's fine if it's primarily the conoid. Yeah, and then but it's basically ossification of the ligaments. In this case, would be kind of a pseudo arthrosis. Okay, well, why don't we stop here and we'll continue next time. Oops.
Tomorrow, John?
Tomorrow, yes.
Or Monday? Oh, tomorrow.
Tomorrow.
Well, have a good evening.